Hospital, Ruby Hospitals and Apollo Clinics. So with this short introduction, I would now like to hand over the session to Dr. Ghosh.
Thank you, Dr. Ajit, and a very good evening and a very warm welcome to all the delegates. So basically, this is going to be an interactive session. This is not going to be a didactic lecture. So we are going to talk about the physicians, our perceptions about triple therapy for asthma, not for COPD. We are going to focus on asthma. We know that triple therapy has been there, tiotropium and glycopyridinium has been used for, the LAMAs have been used for COPD, but we are not going to focus on COPD. We are going to talk about asthma and the role of triple therapy in asthma, and when and what should be its place in the treatment algorithm. So this is a very brief background. There is a need for something else. We can use certain drugs for these patients to control their asthma and at an earlier stage of asthma. So this imposes an unacceptable burden on the patient's quality of life, on the healthcare systems of course, and on the society at large. In patients with asthma who are uncontrolled, despite receiving medium to high dose of ICS-LABA, addition of a LAMA improves lung function, reduces the number of exacerbations, and is recommended by the current GINA guidelines. As the last year 2023 guidelines, we know that LAMA has been included in the guidelines of GINA. So recently, almost all the companies have come up with certain triple therapy combinations of ICS-LABA and LAMA in a single inhaler. However, there is to some extent a lack of understanding on the perceptions and positioning of these combinations for the management of asthma in India. When do we start this triple combination? At what stage? So this is what we are going to talk about today, and we are going to discuss basically. So this, as Dr. Ajit has already said, this is going to be a sort of interactive session and a question answer session. So there will be an opinion poll. So this is the first question that we have come up with. How many asthma patients do you see in a month? I mean, anything, less than 30, 31 to 50, more than 50. We can go to the poll.
1 second. It will load.
Just let it load.
You guys can see the question on your phones after we click on show question here. That's why you're not able to see the question. Yes, yes.
Are they able to see it?
They won't, because we still have to.
Okay, this is coming up.
1 second. Actually not connected. Refresh it.
All right.
You need to
So
click on
show questions. Okay.
You can just enlarge this. Yeah. If you're not able to see the question on your phone, you should ideally be able to see it on the link you registered. If you're not able to, then you need to scan it again. So.
Yeah, yeah. I think so. Everybody has submitted. There are 3, 4, 5, 7 delegates. Yeah. So let's go to the results. So a lot of people see 31 to 50 patients, some see less than 30, and some see more than 50 patients. So this is not a very important question. So how many asthma patients see in a month? All of us see a lot of asthma patients in a month, and at different stages of asthma. Some of them have mild to moderate asthma, some of them have persistent asthma despite treatment, some would be in GINA stage 3 or stage 4. So with that, it's not moving.
Yeah. And then to move to the next slide, you need to go from here. You click on this.
Okay. So this, we are moving on to slightly more clinical aspects. How do you assess the asthma control in your routine practice? Based on the number of exacerbations, based on the number of times relievers have been used, say in the last 1 month, based on, this will be last 1 month I suppose, the number B. C is based on daytime and nighttime symptoms. D is based on the level of activity limitation. E is based on peak flow and FEV1 variability, and F is any other. There might be some certain other parameters that you as clinicians look for to assess whether the patient is having control over his symptoms. So you can just click your opinion. I think this can have multiple answers, or is it just one answer?
Multiple answers.
You can actually go in for multiple answers because many of them are, I mean,
So there'll be 8 submissions in total now.
okay, fine. 1, 2, 3, 4, 5, 6, 7, 8, 9, 9 delegates. 9. Oh, you are there. 8. They can join.
We need 4 more.
Need 4 more submissions. You must have.
Let them join, and they can also, yeah. There should be 10 people now after they have joined. Let them join. Okay, yeah, sure, no problem. So after they register, they will also be, their names will also be here.
We will now have total 10%.
Yes, sure.
Yeah, just register.
Achha, there are only 7 people who have been shown here.
Yeah,
So somebody else.
2 of them are yet to submit the response.
Yeah, fine.
Who are
So
yet
9
to
and who is the other one?
The other
Because
one, I think they are scanning the person.
so there were 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is 7 and
2 are getting registered. And
so
one
9
and
and
1 more is getting registered.
he's
So we'll just announce the name.
Dr. Rishabh and Dr. Suresh.
Started it, so they need to answer question.
Right. So we go back to the first question because some other people have joined, and this is the first question. How many asthma patients do you see in a month? And this is the QR code. You can just scan it and less than 30, 31 to 50, more than 50. You can just click anyone. This is not a very important question. जो भी हो दे दीजिए, no problem. आई एम डॉक्टर कौशिक घोष, कोलकाता से.
कलकत्ता वाले अच्छे क्विज मास्टर.
Starting from the Siddharth Basu zamana.
राजा सर
राजा है. So we have all the answers 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay. So, okay. So then we'll have to restart again from the back end. Okay.
I told them now. So we are so sorry. Now nobody will come. Maybe I have told them.
ठीक है.
Nobody will come now.
He called me thrice to come in the lecture. That's why he came.
Yeah, ठीक है. Yeah, कुछ discussion नहीं है. Right, okay. So everybody has submitted and we'll go for the results. So most of us see more than 30 patients a month, some see more than 50 patients a month and some see less than 30. Okay, fine. So this is not a very important question, as I said. Let us go on to the next question. Yep, यहाँ पे ना
दूसरा वाला इसके बाजू वाला
इस वाला ठीक है. So this is a more interesting question. How do we assess asthma control in your routine practice? So when a patient of asthma comes to you, and what are the parameters you look for to understand whether the patient's asthma, whether the patient's symptoms are under control or not? Is it based on the number of exacerbations that he's having over the last 6 months or 1 year? Based on reliever usage in the last, it will be 1 month, based on reliever usage in the last 1 month, based on daytime and nighttime symptoms, based on the level of activity limitation, based on measurements of the peak flow and FEV1 variability, or any other things that you look for. So you can actually have multiple options, you can click on multiple options. So let us go for the polls. And here's a QR code.
Ideally, they don't need to scan it. It will automatically show on.
Yes, it will automatically be shown on your mobile. You do not have to scan it.
hasn't answered from the panel there. No, don't click on show result because हाँ 1 second वो थोड़ा load हो जाएगा.
I think everybody has submitted. So let us look at the results. Yes, I mean, this is obvious. I mean, we look for the number of exacerbations that the patient is having, and along with the number of exacerbations, obviously the patient would be having more amount of reliever usage, maybe a short-acting beta-2 agonist, based on daytime and nighttime symptoms. That's the third one. Based on the level of activity limitation, based on peak flow and FEV1 variability, and any others. Is that, I mean, this is what we look for. I mean, the number of exacerbations that the patient is having, and whether the patient is having symptom control or not. That's what the patients come and tell us. That we are still having cough, we are having shortness of breath, we cannot perform our daily tasks. This is obvious. Okay, so let us move on because we are already late. What percentage of your asthma patients, just asthma patients, not COPD patients, are uncontrolled despite using medium to high dose of ICS/LABA? Nowadays, almost all of us are using ICS/LABA for asthma patients. So despite using, say, 4-accord 2-pulse BD or whatever, despite using medium to high dose of ICS/LABA, what would be the percentage of patients who are still uncontrolled? The questions would come on your screen and you can now vote for it. Is it less than 5%, 5 to 10%, 11 to 20%, 21 to 30%, 31 to 50%? A single answer, please.
You can check from the panel who is yet to answer. The grey ones are yet to answer. I think this is missing. And then we got Dr. Raghudeep.
Yeah, Dr. Raghudeep is yet to answer. Do you need the QR code? You can scan it here. Yeah.
Open website.
Right, and the results are, so the majority says that almost 5 to 10% of the patients are uncontrolled with medium to high dose of ICS/LABA. In fact, if we go a bit further and look what the international studies say, studies report that even a more number of patients, more number of asthmatics remain uncontrolled despite use of ICS/LABA. So it's to the tune of almost 30 to 60% in some studies. And there are certain patients who had severe exacerbations to the tune of almost 8 to 16% patients. So a significant number of our patients, this is international studies, I mean even India has, this is your perception, about 5 to 10% of the patients do not have controlled asthma, they have uncontrolled asthma, they are having frequent exacerbations. Now what will be your preferred line of treatment for asthma patients? Uncontrolled with medium to high dose of ICS/LABA. So do we look for another cause of the symptoms? So we have to recheck our diagnosis, we have to look for the other DDs. Evaluate inhaler technique and adherence to medication. I think this is a very important aspect which we all do look for in a patient who is not being controlled with the standard dose of medication. Do we increase the dose of ICS in the combination, or do we switch to a different ICS/LABA combination? Do we switch to a different inhaler device? Do we add a LAMA, or do you start biologics and any others?
Ghosh, here they need to rank those options in order. So if
Okay, so you have to rank the options in order. I'll go to the next slide and show the questions. This is,
maybe after this question, we will take your opinion.
yeah, sure.
Can you show the mic?
Yeah.
You can ask few people this question if you want this question. We'll wait for one answer. Doctor.
Yeah, so we have all the results. Yes, the maximum number of clinicians say that we have to evaluate inhaler technique and adherence to medications. I think that is the most obvious thing that we have to do before switching a combination or before switching to a different inhaler. What would be the, I mean, this is not here in this questionnaire, but what would be the percentage of patients of our asthma patients or COPD patients, any obstructive airway disease patients who are not using their inhalers correctly? In my practice, I would say more than 50%. And what is your opinion all over India? Absolutely. And we have to take time out from our practice to teach them. We have to spend time with the patient. If it's not possible for the clinicians, then we have to have some helping hands, our compounders or whoever, who have to teach the patient. Because without teaching the patient the correct inhaler technique, just giving an inhaler, just prescribing an inhaler makes, I think, no sense. So after we have evaluated the technique of the patient and we are satisfied that he is taking the medications correctly, then what? The next is, I would say, the opinion polls say, look for another cause of the symptoms. Yes, this is very important because the patient might be having bronchiectasis, patient might be having some amount of interstitial lung disease. So this is another thing we have to look for, review the diagnosis. And after reviewing the diagnosis, the next thing we can increase the polls say that we have to increase the dose of ICS in the combination. So we have two options. When the patient is uncontrolled, when the patient is say in step 3 of GINA or step 4 of GINA and the patient is uncontrolled, we have two options. We can either increase the dose of ICS or we can add a LAMA. What will be your opinion? I mean, which is preferable? Yes, that is, I mean, that's what Gina is saying, and all the current research is saying. But
High dose of ICS already is there. So including ICS on that.
yeah, maybe in step 3, when we are using medium dose of step 3 or step 4, when you are using medium dose of ICS. I mean, here lies the thing about targeted therapy. We have to look for the phenotype of the patient. I mean, we know that there are two types of pathophysiology in asthma patients, whether they are eosinophilic predominant or non-eosinophilic predominant. So the patients who benefit from increasing the dose of ICS are the patients who have predominant amount of eosinophils in their sputum. And if the patient is not having eosinophilic inflammation, just increasing the dose of ICS would, I don't think would serve any purpose. It will just increase the maybe side effects. Although it's a topical application, but still increase slight amount of ICS would be absorbed, and that will lead to side effects. So in those patients, adding on a LAMA, I think would be preferable. That's, I think, I mean, the consensus.
Not missing that one should also include comorbidity in the choice.
Of course, yes, of course. The patient might be having, yeah, the patient, we have to look for the diagnosis. I mean, in diagnosis comes that. I mean, the patient might be having some occult heart failure. As I said, patient might be having, elderly patient might be having some amount of interstitial lung disease or hypersensitive pneumonitis. We do not know. We have to look for those things. Okay, so should we move on to the next slide? Again, a poll, what percentage of asthma patients who are uncontrolled on medium to high dose of ICS LABA do you see in a month? Would you prescribe a triple combination? So uncontrolled asthma patients in your practice, what percentage of them would be prescribed an ICS LABA LAMA combination by you? Is it less than 5%, 5 to 10%, 11 to 20%, 21 to 30%, or more than 50%? So let us show the questions. Yeah.
Yeah, a few more. Sir.
So more than 50%, an overwhelming majority of doctors say that more than 50% of the patients would be prescribed a triple combination. And should the triple combination be prescribed in a single inhaler or multiple inhalers? Should it be an, yes? This is just a discussion. I mean, there's nothing right or wrong here.
Yes, I request everyone to please speak on the mic because it is getting recorded.
You
Can we have a
just
round of
pass
opinion
on the
also?
mic, yeah.
Yeah.
I think the single inhaler is a better choice. If we want to use multiple inhaler, then it should be of same type, because sometimes patient have many more error if we prescribe them different inhaler for LAMA and he is using different inhaler for ICS LABA. So this is my choice.
Yes, doctor, anybody?
Initially, I prefer separate inhalers for the patient, and later on, as per the effects and the patient compliance, and the patient also feels like that afterwards the doctor has reduced my inhalers to one inhaler. So
That's just a
that
psychological
placebo effect
thing. Okay.
is also there. So initially I start with the multiple inhalers, then later on I switch to single inhaler therapy.
As sir said, I mean, if we combine it in a single inhaler, obviously the adherence level goes up, patient's acceptability levels go up, and also the cost comes down. But you also have a point. So if the patient has a side effect with one particular component of the drug, so if you're using it in a single inhaler, you won't be understanding which particular component is leading to, say, tachycardia or whatever. So using it in a different form has certain benefits. But most of the patients would be prescribed the triple combination in a single inhaler, and we have the single inhalers now, we have MDIs also. So moving on to the next slide. This is the most important slide for all us prescribing doctors, whoever is treating asthma patients, because this is the GNAT 2020, the latest guidelines. So I think everybody will not go into details of this. We all know about this. There are two tracks, track 1 and track 2. First of all, we have to assess, adjust and review. That goes without saying. That is what we have been discussing. And then after we confirm that the patient is having a diagnosis of asthma, then we can actually go for two tracks. The track 1 is the preferred track, in which we use, which is basically the smart track or rather. So we are using an ICS LABA, that's ICS formoterol combination, both as a reliever and as a preventer. And track 2 is the alternative track, in which we are using a SABA as a reliever, and whenever we are using a SABA, we should also use an ICS, because that leads to lesser number of exacerbations. So this is the GINA guidelines. This is the mechanism of action. For paucity of time, we are not going to go into details. We know about how ICS acts, how LABA acts, and LAMA acts because it blocks the M3 receptors, which are there in the bronchial mucosa, and because they have a targeted therapy, the side effects, the cardiac side effects, the urological side effects are lesser with these LAMAs because they mainly act on the lungs. Now, various studies show that ICS LABA-LAMA combination shows greater improvement in FEV1 and reduction in exacerbations as compared to just a dual therapy with ICS LABA. The same things, triple therapy resulted in greater improvement in asthma control and quality of life as compared to the dual therapy. Now, again, questions. Which of the following LAMAs would you prefer in your patients with asthma? We have three options now in India. We had tiotropium for the last 10 years, more than 10 years. We have been having tiotropium for the last 20 years. We now have glycopyrronium, and we are slowly having umeclidinium. So which would be your preferred LAMA? Let's show the questions. And this is the QR code. And after we have our opinion poll, let's discuss why we should have this particular LAMA. We have all the answers. Sorry. And the results, an overwhelming majority says that we have to have glycopyrronium. Now, why not tiotropium? So we have been using tiotropium for the last, as I said, 20-25 years, and it's a very safe drug. And nowadays, the guidelines say that we can use tiotropium for children as low as 6 years. So a patient who is more than 6 years, we can use tiotropium. This was unthinkable about 20 years back. So tiotropium was only for COPD patients, it was only for adult patients. Nowadays, we can use it for children also. So why not tiotropium and why not umeclidinium? Let us keep umeclidinium away from our discussion because it's a new drug and we do not have a lot of experience of using this particular molecule. But we have been using tiotropium and we now have glycopyrronium. So why glycopyrronium and not tiotropium? Anybody? Probably yes. Because all the golden studies show that the golden studies have been done with glycopyrronium, and the level of side effects are, especially the cardiac side effects, because we are always concerned about the cardiac side effects. There are basically two side effects. One is the cardiac side effects and one is the urological side effects, because they cause urinary retention or stuff like that. So I personally do have some patients of tiotropium who have had urinary retention. What is your experience with tiotropium?
Definitely, that is there. Even dryness of mouth is a
dryness of the mouth is a very important, another very important. It's not a serious side effect, but it's a very irritating side effect for the patients. And tiotropium, as I said, I mean, we are now using LAMA for asthma very currently. We were using LAMA for COPD patients, and most of the COPD patients are elderly patients. So those patients have cardiac side effects because most of them will be having hypertension, ischemic heart disease, diabetes, dyslipidemia, etc., etc., etc. So probably glycopyrronium has lesser side effects as compared to tiotropium, probably. But there are few patients who are doing very well on tiotropium, and if the patient is doing very well on tiotropium, why change to glycopyrronium? It serves no purpose. If the patient is having symptom control and if the patient is fine with the drug, there are no side effects, then there's no point changing. And we also have triple combinations now with tiotropium, I suppose. So let us move on to the next question. So why would you prefer the LAMA for your patients with asthma? More effective as compared to others? This particular drug, say we have chosen the overwhelming consensus, 12 out of 13 doctors here say that we are going to use glycopyrronium as compared to either umeclidinium or tiotropium. So why choose this particular thing? Is it more effective? Is it safer? Is the documented safety and efficacy better? One is our experience, more effective and safer, and whether the documentation says that is more efficacious and safer than the others, is it less expensive or any others? So let us go for the opinion poll.
This comparison is to what? Basically,
To tiotropium, because we do not,
LAMA, they are saying
one LAMA as compared to other. Why are we choosing glycopyrronium? Because we chose glycopyrronium. The consensus in this room was glycopyrronium
versus tiotropium.
versus tiotropium, because umeclidinium is a new drug. We hardly have any experience of using it.
You can choose multiple options. In this.
Yeah, you can use multiple options.
Can we have a round of opinion on this question?
So everybody has submitted. More efficacious as compared to others, safer as compared to others, and documented safety and efficacy. This is what we just discussed. So these are the things. It's obviously more expensive, so it's not less expensive, and there are no other aspects to it.
But in
So I-
triple drug, it is not expensive also. In triple drug combination,
It's not expensive, yeah.
They are
It cuts
similar
down the
now.
cost, yeah. The cost comes to be almost similar. In fact, if you are using tiotropium in a multiple, in two other inhalers, one ICS LAMA and tiotropium, then the cost is higher. Okay, which of the following would you prefer for your patients with asthma? What we already discussed, either a single inhaler triple therapy or a multiple inhaler triple therapy, and why? So we'll discuss why later. So let us go to the opinion poll. Yeah, sure. Now I think everybody has. Achha. We need one more submission. Dr. Rushav, I think, has not submitted. Dr. Rushav. Oh, okay. Okay, so we move on. So single inhaler triple therapy. Any of you have any opinion about, we have already talked about cost and everything. Anything else?
this is what I want to say. Do we have
You can use the mic.
Do we have the data where it says that single inhaler triple therapy is to be given in asthma
We have a few US studies.
studies?
Yes, we have a few US studies in which LABA, ICS LABA in one inhaler and tiotropium in another inhaler was compared vis-a-vis triple combination. So the triple combination scored better, but the results do not say whether it was due to better adherence or due to better efficacy. I have gone through that particular US study. There were 2 or 3 US studies. There was a meta-analysis where it said unequivocally that triple therapy, single inhaler triple therapy scored better over dual therapy, but it did not say whether it was due to better adherence or whether it was efficacious, more efficacious.
Yeah. So basically, and one more thing, ubiquitinium what we are discussing, it's mainly we study in COPD. अस्थमा में बेसिकली उसका रोल है नहीं. Second is what the studies what we are discussing mostly COPD based. Asthma based studies
Absolutely.
for single
Yes.
inhaler therapies are very rare basically.
Yes.
So what he's trying to point out is the thing that COPD studies we have. That is why they are saying the single drug, that is single inhaler therapy.
Probably, yes. Because Gina has come out with LAMA in the therapy armamentarium just 1 or 2 years back. So we never used LAMAs for asthma patients, but now it has come into the guidelines. Anything else? Anybody?
Basically, those 3 studies which you're talking about, there was a improvement in the symptom control, but they did not reach the statistical significance.
And
So
there was,
that is-
yeah.
That is why I
You are
still
right.
have reservations for single inhaler triple therapy till the time we get more, authentic data on
Sure.
that. So,
And that was with tiotropium, not with glycopyrronium. I mean, glycopyrronium triple therapy was compared to ICS-LABA plus tiotropium.
but they had iridium study also.
Iridium
there,
study, yes.
There was glycopyrronium also.
Yes,
which
one
the-
study is
the
showed
other their contenders Defisma, which we have you must have seen. They market it as that this is the study iridium which shows that single inhaler triple therapy. But still, I have reservations for single inhaler triple therapy in asthma. COPD, we all know COPD. We are giving left, right, and center. Even umiclidinium, we have experience now in COPD. A very good experience with umiclidinium, where we have seen improved lung functions, minimum number of exacerbations and hospitalization in our COPD.
Absolutely.
But for asthma, I think single inhaler is still.
And these studies which we are talking about, they showed better, improvement in the number of exacerbations, but symptom control was not so. Absolutely, yeah. Symptom control was not so good, but the number of exacerbations were reduced. Yeah. That was in COPD. I mean, asthma, you hardly get any studies. Okay. And then which will be the preferred combination for asthma? All sorts of combinations. Which would be your preferred combination? I think this will be only on one answer or multiple answers.
I think the language diagram also not- you can- Yeah, you can go to show question.
One, yes. You can take some time to read the combinations. There are a lot of combinations. सभी का हाँ sure. After we finish, then we'll introduce everybody. Sure. And so we go for the results. Formoterol budesonide glycopyrronium combination twice a day. Twice a day.
This still is a controversial question.
Yes. So whether we should use it once a day or twice a day?
once a day.
Budesonide also once a day. So if we go for this combination,
Cyclosinide
formoterol,
combination,
budesonide,
yeah.
glycopyrronium,
Then it is twice a day.
okay. So this is our opinion.
Yeah, tiotropium and that cyclosporine combination and formoterol, that might be taken for the once a day therapy.
Yes. Tiotropium is once a day always. Even cyclosinide. No, everybody is ability. Yeah, sure. So why would you prefer the above triple combination? More effective as compared to others? Let me just read. Safer as compared to others, better documented with respect to efficacy and safety, less expensive, easily available. Availability is an issue, especially some of us who practice in resource constrained settings in the rural areas. So whether they have, because they have once daily dosing frequency, whether they have because of twice daily dosing frequency, better device, improved patient compliance, or any others. This is individual opinion. This is an opinion poll. I mean, there's nothing right or wrong here. This is an opinion poll.
I'm requesting a round of opinion as well.
So most of us say either of the two, it's more effective as compared to others and improve patient compliance. Okay. 4% say that has once daily dosing frequency, and some say that is safer as compared to others. Okay. All these points are important. So we move on to the next question. In your opinion, is there a particular patient profile that would benefit with early initiation of triple therapy? This is a very practical question. They will have to write it down, isn't it? Yeah. There are no options. Any particular patient profile? We do not do phenotyping for every patient in our country. So just clinically, any particular patient profile who would benefit from early initiation of triple therapy, basically early initiation of LAMA. Yes, elderly patients maybe. History of smoke exposure, passive smoking. After we come to the results of this particular question, let's have a discussion, because this is something to be discussed. Answers
to discuss, I think.
This, yeah. Let us have your opinion. Anybody has anything to say? Which particular patient profile would you initiate LAMA early, or triple therapy early rather?
So in the age group point of view, sir, elderly will be preferred.
Okay.
Then next is the spirometry is done, then very severe obstruction already on the day one, it's the first spirometry, then also preferred.
Okay.
Smoker, as you already said, that smoker and non-eosinophilic predominant variant of asthma, definitely
Yes.
they will be preferred. So,
At least eosinophil level we can always do.
Eosinophil. So how do you decide with the eosinophil levels you have to put the patient on triple therapy?
Now, what the studies say, you have to do the sputum eosinophil level, more than 2%. Then you say that the patient is going to benefit from escalation of ICS. And if the patient's
That is for
sputum
ICS. So frequent exacerbator? Would this be your
yes, I mean,
prerogative to put?
the frequent exacerbators, well, if the patient is going to benefit from higher dose of ICS, there are certain patients who are going to benefit from higher dose of ICS. There are certain patients who are going to benefit from oral corticosteroid therapy. And there are certain patients who benefit from theophylline, especially doxyphylline. We are not using derifylline nowadays, doxyphylline basically. There are certain patients who benefit from leukotriene receptor antagonists. So there are multiple phenotypes, and we have to do a individualized approach to every patient. I feel, I mean, there are certain patients who have a lot of sputum production. So those patients maybe would be benefiting from LAMA therapy earlier, because muscarinic antagonists act on the goblet cells more than the ICS. So patients who are having a lot of sputum production would probably benefit from anticholinergic therapy. But these are gray areas. I mean, there is no clear-cut guidelines here till now.
If the reversibility is not too good,
Okay.
then we can use triple drug combination basically. If the reversibility is not too good, so there is what
So
we say is a
reversibility-
COPD overlap syndrome most likely.
Yes.
What we are expecting in that subset of patients. So.
So individualized approach basically. We do not know till now which are the patients who are going to benefit. So these are certain treatable traits in asthma. There are multiple treatable traits, and LAMA, ICS, LABA, LAMA combination actually has beneficial effects on almost all the treatable traits as compared to a dual combination. So these are the things, these are the traits which you should look for in a particular patient, especially neuronal, there's something called neuronal plasticity. So these are the things you have to look for before you start triple therapy. Now the next question, what are the other asthma medications you would concomitantly prescribe along with triple therapy? Inhale SABA, inhale SABA-SAMA, nebulized SABA, nebulized ICS LABA, nebulized SABA-SAMA, leukotriene receptor antagonist plus antihistaminics, theophylline, or any others. Leukotriene receptor antagonist plus antihistaminics. I think we all use it. And what is the duration of the antihistaminic that we use? Levocetirizine for how long? Montelukast we can of course continue for 6 months to 1 year, but levocetirizine for how long? What's the normal practice? Forget about the guidelines. What is your normal practice?
I do it for 2 weeks,
2 weeks, yes.
then I switch back.
To just Montelukast. And Montelukast for 6 months?
Still like
Yeah. And there are some patients who do very well on Montelukast. There are certain patients who are not taking any inhalers and they are continuing on Montelukast for a prolonged period, and you start them on an inhaler, ICS-LABA combination maybe, and you try to switch off Montelukast and the patient starts to have symptoms. I mean, I think this is a practical aspect which you all have faced, we all have faced. So there is, we have talked about the alternative pathway of inflammation where Montelukast acts. So maybe there are a subset of patients who do very well on Montelukast. Okay. Would you consider starting triple therapy in all your uncontrolled asthma patients before evaluating them for biologics? Yes or no? I think everybody would say yes here. Okay, yes.
If you go there, you can see one of them is yet to answer. Ideally, let's go ahead after everyone is answered.
But I think not, everybody is not present here. Okay, so yes, so let us discuss, let us put the question in a different way. So why not biologics? Why not early use of biologics? Biologics are not bad things. Cost, if you forget about the cost. Pardon, can you give him the mic?
Not all cases are eosinophilic predominant. The mechanism of action is different. Eosinophilic part is already been taken care of by the steroid and the leukotriene receptor antagonists.
Okay.
Sir, biologics, there are some, we don't have all studies basically because of it. Some have patient, unfortunately have reactions also because of that. So one more thing, because Indian public, people started using it, I myself have used it, but thing is not very confidently in all the patient we can use it, means every, no. In future, it might be possible that we can have gene therapy also, that basically, so when the patient is coming, usko ye de do, uska gene change ho jayega, treatment is done. So maybe the future is biologics and other things, but presently, people are skeptical using it for in the early days, in the early practice.
Even with biologics, when we use biologics, that patient is totally not off their inhaler therapy. So the cornerstone still remains the inhaler therapy. So there might be time when we only upfront start giving biologics, but not today. And the other thing which sir mentioned, that there is also switching of biologics. If one biologic is not responding, then you are switching biologics. So we know that if we have a therapy, triple therapy, which we will give and patient will have relief in symptoms. So I think cost is an issue in India.
Absolutely, cost is an issue, yeah.
So these 3-4 issues, I think still biologics before giving inhaler therapy, still we'll have reservations with that.
There were certain patients, severe asthma patients, when we are using omalizumab, anti-IgE. So some patients responded very well, but not all patients. So again, choosing the patient is very important, in which patients to give which biologic. But how to choose the patients, the guidelines are not yet clear. I mean, which particular patient would receive which biologic and which particular patient should at all receive biologics. I think we have still not come to that stage of development. There are certain non-pharmacological therapies which even GINA is recommending, like HDM slit, if the patient is having house dust mite allergy. So those are the things which are not available in India, but those are the things which we maybe would be looking at in the future. So those are cost-effective measures, and they're would be very effective measures also. Okay. So there is something called HDM slit, house dust mite slit, that is sublingual tablets are used. Immunotherapy is immunotherapy.
That is already in practice.
Yeah, I mean they had that, Lupin had one.
That was already in practice for many decades in India. Not sublingual, but intradermal. Sublingual is not, as per the government has not given sanction to that.
Sublingual.
But the many companies are manufacturing it and providing it, and people are using it. Though sublingual is not legal as per now till date, intradermal is being used. I have been using it for the past 2 decades.
Right. There are special
And-
allergy specialists, basically, who are doing only allergy work and do fantastic work with that things. Results are fantastic.
Okay. But is that SDM slit?
I'm not doing myself. But I've done, I've seen the results.
Is that house dust mite slit?
Previously, an allergy test has to be done. In the Western studies, house dust mite is the most common culprit.
Yes.
And initial remedial measures like covering the blanket with polythene sheet has to be done.
Okay. Those
And
are
then we can go for sublingual immunotherapy or intradermal immunotherapy for the antigens involved, in which house dust mite concentration we provide and the manufacturer.
No, that
makes
is the immunotherapy. That is a subcutaneous immunotherapy.
yeah.
That's what I'm saying. We are
Slit is
talking
the
about
same thing, sublingual
sublingual.
immunotherapy.
Yeah, I'm not talking
That
about.
is also being provided.
Yeah, it's the same. The thing is the same. Okay, this is the GINA 2023 guidelines recommend use of non-biologic treatments, including llamas, before considering biologics. That's the consensus we have all come to. And what would be the two biggest challenges, in your opinion, for prescribing triple therapy for your asthma patients? I think this is the last question. And this is just an opinion. You have to just write down your opinion. Two biggest challenges for prescribing triple therapy. So should we go to the results? 1, 2, 3, 4. We can wait for one more result. Yes. What were your answers? I mean, we cannot see it on the screen. Biggest challenge for prescribing triple therapy? Cost?
One is the cost and second is availability, sir.
Cost,
things.
availability. Cost of therapy.
If
Cost.
there is not any big challenge, if patient is not controlled with the ICS and LABA, then we have the option of using a triple therapy. It should be used before going for OCS or biologic.
Absolutely.
This is single inhaler triple therapy or multiple? Single?
Single inhaler, yes.
Only single, then this would be same inhaler for reliever as well as maintenance. That will be a challenge. Because Vilantrol fluticasone when combination came, we were giving it as maintenance, but there were no, we had to give another inhaler for the reliever part of the patient. So that is why we still feel that the combination should be reliever as well as maintenance.
Yes,
And
that's a very good part. Whether we can use the triple combination as a smart therapy, right? That is a very important point. There should be more research on that, whether we can actually use it for reliever also. Okay. So with that, we come to the end of the discussion. So as Sir said, why don't we introduce ourselves, starting from the end?
Good evening, everyone. My name is Dr. Vikas Garg. I am from Chhattisgarh, and I am an emergency physician.
Right.
Thank you.
Thank you.
Good evening, everyone. Myself, Dr. Shyam Vashani from Chhattisgarh. I'm a pulmonologist.
Thank you.
Good evening, everyone. I'm Dr. Abhinav Bhanot from Delhi. I'm a practicing pulmonologist.
Thank you.
Yeah, hello all. I'm Dr. Kinjal Modi. I'm a chest physician practicing at Hinduja and other hospitals in Mumbai.
Mumbai.
Myself, Dr. Zishan. I'm practicing in Sendwa. It is 150 kilometers south of Indore at MP Maharashtra border. I'm practicing in a private setting. I'm extremely sorry to interrupt you guys, but I just wanted to put so many questions forward. But having said that, I come from a place which actually is a very small place. When we were having discussion about this question, the only single factor that came to my mind is when we are talking about say for example the studies, the articles, the researches, the meta-analysis, so on and so forth. The only single factor that I see in my practice which is responsible for the failure of the drug is compliance. And compliance, that's it. N number of times if you tell the patient that this drug is going to help you, this thing is going to help you, one, they have phobia against it. Second, I'll tell you the incident that happened day before yesterday in my clinic. I had a patient, I've been seeing that patient for long. He came to me, I repeatedly kept asking him because he was not controlled, that are you taking the drug? He said in the plain language, what he said, I'll tell you, भगवान कसम मैंने एक दिन भी ऐसा नहीं गया जब मैंने दवाई नहीं ली. And I was trying to explain it to him कि अब अपने को ऐसी दवाइयाँ लेना है, ऐसी दवाइयाँ लेना है, अब अपने को ये करना है. And to your surprise, as soon as I ended the discussion with that patient, the daughter walks into the chamber and he's like कि सर पापा ने 5 दिन से दवाई नहीं ली. No, but why are, as in, if you're talking about the practicality of the drugs, as in if the drug is going to work or not, if at all whatever you're prescribing is going. Yes, they will bring. Yes, they will check the technique, but they will not be using the drug itself. Apparently they have a phobia, and there will be one irritating person in the society who will keep repeatedly telling them कि इसको नहीं लेना, इसका आदत लग जाएगा. And I'll have to explain it to them every time they walk into the chamber.
That is a practical thing which we all face. That is.
No, I think that is the only thing that I am worried about, as in how do we overcome that thing? Maybe it's the failure on my part. You people are all senior to me.
It's repeated counseling, I suppose. We have to just.
Education. Nothing is there.
Sir, but the thing is, the place where,
things are available.
Support program which they have, so that they can go to your patient's place and they can try to convince them of these things.
sir, if you guys, if you people are practicing, I consider that you are practicing in a place where you are either in a tertiary setup or either you are in a metro city. You will have patients who will listen to you, but in a place like mine, 99.99% of the patients I have are rural patient or Adivasi for that matter. They will not listen to you. They will not listen to you. Whatever. Sir, I have been quoting one example for the last, for last 5 years, I have been quoting that example. I created that example by myself. I keep telling them कि अगर तुमको कहीं चोट लग जाता है और आप आते हो कि सर मेरे को दवाई लिख दो, मैंने आपको अगर कोई क्रीम प्रिस्क्राइब किया, मैं ये भी नहीं बताता हूँ तुमको कि कहाँ लगाना है उसको, बट तुम क्या करते हो, उस क्रीम को लेके जहाँ चोट लगी होती है वहाँ लगाते हो. ऐसा तो नहीं करते कि तुम उस क्रीम को लेके यहाँ भी लगा लो, सिर पे भी लगा लो, ऐसा भी कर लो. Why you don't do that? Because it is not.
Everyone, अगर आँख में कुछ you are putting eye drops, you are putting.
But they will not listen to you.
Ointments.
Then you can't do anything. The thing is,
if the patient does not want to be helped,
I told the patient that
there are certain
this is the
resistant
salt,
patients
this is
like
available
that,
in syrup also, this is available in inhaler also, injectable also. The quantity is different. If they understand, it's okay. Then they are more of having GP and Jhola Shah practice. They are happy with them. Then you can't do anything.
Yes, that is one
Education
another
is
thing
As you
important.
said,
that
I
is
mean,
happening.
the patient preferences are important. I mean, there are some patients who would do very well on nebulizers and they will continue to use
Yes,
nebulizers.
yes.
They won't be going for inhalers. Yeah.
They don't have phobias with nebulizers because they have seen children getting
Sir, they don't have phobias with nebulizer. They don't have phobias with only one thing, that is jhola chhap practitioners. They will not have phobia with them. I don't know if in metro cities it is common or not, but in my places,
Very common.
कि
Your
अगर
problem is nothing new here.
अगर
What we are trying to tell you is
हाँ.
this is nothing new problem for all of us.
But sir, I mean, do we have a solution for that? Because discussing so much of drugs, I don't think it makes a point.
See, dear, basically for same things, TB medication also government has worked very hard for that. You remember that? They have even have the program कि वो medicine खोला ना तो भी SMS जाता था. They have still system that way. पर वो medicine खोला और मुंह में गया ना उसका आज तक कुछ भी नहीं हुआ है. So that's the problem. So thing is buying the medicine, getting in their home, taking a proper technique और उसने खुद से लिया ना only simple thing जैसे आपकी बेटी जो थी पेशेंट की बेटी थी मीन्स यू हैव टू अपॉइंट वन इंस्पेक्टर इन द हाउस. वो देख लेगा उसको पूछने का लिया कि नहीं ठीक से. पेशेंट सही बोल सकता है इफ़ द एजुकेटेड वेल एजुकेटेड बोलेंगे अच्छी बात है. विश्वास है अच्छी बात है, नहीं है तो सेकंड इन लाइन किसी को रखो. मिला तो आंसर ठीक है, अदरवाइज सी उनको ठीक होना है. वी आर द पीपल हु आर गोइंग टू जस्ट एडवाइज देम मेडिकली. ठीक होना नहीं होना उनके ऊपर है. सम पीपल वांट टू स्टे विद द लेबल ऑफ अस्थमा फॉर लाइफ लॉन्ग, तो इट इज़ अ ओनली डिजीज विच इज रिवर्सिबल. बट दे डोंट अंडरस्टैंड दैट. नहीं, हमको ज़िंदगी भर चलाना है. मीन्स वो 2-4 महीने आएंगे जैसे कौन माई प्रैक्टिस ऑल्सो समर वैकेशन मीन्स समर में 4-5 महीने गायब हो जाएंगे. फिर अगेन जैसे मानसून आया, सर वो थोड़ा मेडिसिन बंद हो गया था, ये हो गया. मैं सबको सुन लेता हूँ, ठीक है इट्स ओके समर वैकेशन, मुझे प्रॉब्लम नहीं है. बट थिंग इज यू टू अंडरस्टैंड दैट आपको ठीक होना है, सो यू हैव टू गेट द मेडिसिन प्रॉपरली. इफ यू आर ऑन प्रॉपर मेडिसिन इट मे स्टॉप ऑल्सो एट वन पॉइंट ऑफ टाइम इफ यू नॉट वेरी सीवियर और समथिंग लाइक दैट. अदरवाइज विल कंटिन्यू. सो काउंसलिंग एंड सम पॉइंट ऑफ टाइम वी ऑल्सो अंडरस्टैंड अवर ओन लिमिट्स ऑल्सो. मैं नहीं कर पाऊंगा सबको ऐसा मीन्स इनिशियल प्रैक्टिस आपको ठीक करना है.
जो 1 घंटा पहले तुम्हारे पास आने से पहले काउंसलिंग ही करे नहीं लगी.
Maybe.
Patients and attendants, right?
And other patient experience, the other patient who are already taking, they are waiting in the same area. They can
Sort of
tell them,
advocacy, yes.
That will be much better.
Sir, I think how it was appreciated, initially there was for insulin, people used to say like no insulin. Now with time, everything changed. Now people accept it. So I
People's
think with time
perception
in
have
future,
changed, yes.
we'll be like comfortable with it.
This simpler people, they have done. Bollywood has always tried to put inhaler at a very bad
Ex-
state. And now these people have come up with their short clips.
Priyanka Chopra and yeah.
TVF, I think you have collaborated with someone that they have made short video reels and all.
इसमें बहुत
They are
written हुआ.
demonstrating कि हाँ inhaler
Inhaler सही है, सही है,
inhaler
ऐसा.
सही है and they are putting this video. Now everyone watches phone. आपकी सुने ना सुने रील्स तो देखेंगे. तो
The same idea used it. One of my patient, she was off, means very good patient. Asthma ठीक हो गया after inhalers off. After 6 months, 1 year also she was perfectly fine. PFT करके उसको बोला एक हेल्प चाहिए, एक वीडियो बना के डालना है यूट्यूब पे. She agreed. वीडियो बना के डाला. एक पेशेंट को बोलता है ना जाके वीडियो देख लो, ठीक होता है. अगर आपको चाहिए तो, आपको ठीक नहीं होना फॉरगेट इट. उतना ही बोल सकते हैं, कुछ नहीं कर सकते. इंट्रोडक्शन
I am Dr. Rishabh Jankar. I am from Gujarat. I am pulmonologist.
गुजरात में कहाँ से प्रभु?
And myself, Dr. Suresh Kumar Goyal, I am working as a senior director in corporate hospital at Chandigarh as a pulmonologist.
I am Dr. Dinesh Mehta. I am professor and head at Adesh Medical College, Kurukshetra.
कहाँ पे था?
Kurukshetra.
Kurukshetra.
Krishna.
I am Dr. Raghudeep, practicing pulmonologist from Hyderabad.
This is Dr. Rakesh from Hyderabad, pulmonologist.
Thank you. So हम लोग स्टॉप कर देते हैं. तुम लोग कुछ बोलोगे?
Yeah, so thank you very much for your
इधर ही था.
for your patience and we really